distinguished colleagues, good morning. I would like to discuss the role of ECT and schizophrenia. Recently there has been some new information that was collected in the recent years. ECT is the oldest biological treatment that is used in modern psychiatry. In terms of its widespread use and its use among physicians, Max Fink played an important role, and there's a quote by this author, and it says what penicillin means for neurosyphilis and what niacin means for pellagra, and this is ECT is the most effective mode of treatment. Now I will discuss the role of ECT on the different symptomatologies of it, to augment the response to antipsychotic treatments and its role in the treatment refractory patients, and clozapine in combination with ECT, maintenance ECT, and some details about the use of ECT in schizophrenia. ECT was first introduced in 1938. The first application was on schizophrenic patients. However, after a short time, it was shown to be very effective on affective disorders, especially major depression episodes. So its use is usually limited to affective disorders, and psychotherapy was not developed yet. After the 50s, with the introduction of pharmacological treatments, so in the last 2 decades, especially in schizophrenia, its role in schizophrenia has been studied extensively, and which patients respond well. So whatever the reason, catatonia has been shown to respond very well in ECT. In many guidelines, it's the first-line treatment with a response rate up to 90%. If we look at the guidelines, we see that for the schizophrenic patients, according to the APA, in case of sudden and the new onset psychosis exacerbations, schizophrenia that is associated with catatonia, and if there is a history of good response to ECT, schizophrenic disorders and schizoaffective disorders can be among the indications for the use of ECT. If you look at the NICE guideline, it is a more conservative approach to the use of ECT. It says there is no evidence for the use of ECT in schizophrenia, therefore it's not recommended. However, if the patient is not able to tolerate the medications, it may be used in schizophrenic patients too. And there's also the fact that it's a new onset is highlighted in the guidelines, and it is a significant depressive symptoms, positive symptoms, and catatonic syndromes. And if it's no onset, in this case, ECT may be used. And if the especially affective component of schizophrenia responds well to ECT, there are some authors that study this topic extensively. This is one of the reviews. ECT is effective on the affective symptoms of schizophrenia, and other symptoms such as delusions, hallucinations, as well as distraction are not affected by the use of ECT. However, if you look at the 60s, since 1960s, studies have been conducted on the use of ECT, and it's been shown to be effective in many psychotic symptoms as well. For example, Shampatana, who has conducted many studies on the topic, it says that the schizophrenic symptoms do not improve with ECT. However, there is some improvement in terms of the symptoms. Hostility, persecution, delusions, as well as other positive symptoms respond well to the use of ECT. Shampatana has conducted a study among 293 treatment refractory schizophrenic patients. They have been studied prospectively. They have not responded to at least 2 classes of antipsychotics. And in those patients, ECT in combination with flupentixol has been attempted. And if there's an improvement by 20% at least based on MDRS, and if the improvement persists for 2 weeks, this indicates a positive response. And among there is 54% of the patients respond to this treatment, and there is a significant improvement in terms of positive symptoms. The is a moderate improvement in the signs and symptoms of depression and anxiety. There's no improvement, or there's even an worsening in the negative symptoms. In the same study, in the non-responders to the ECT, they looked at the different predictive factors, especially frequent psychiatric admissions, and respond well, and there is a shortening of the disease duration and no family history of schizophrenia, and that the SMMT score is high, has been shown as a predictive factors. However, in both of the groups, negative symptoms are more or less pronounced, and the duration of the current attack is shorter, and those patients respond better to ECT. And we can conclude that especially the negative symptoms do not respond well to the ECT treatment. In 2008, Tarian and Adams have a very extensive review article. 26 studies have been included. 50 publications are included in this review article. Schizophrenia, schizoaffective disorders, and chronic mental diseases are included. And here ECT, placebo or sham ECT are compared. And the conclusion from all of the studies, the number of patients that improve with real ECT is more than with the sham ECT. In the short term, there's also less relapse rate in the real ECT group. However, in the long term, this advantage does not persist. And the two arms converge. And there's a better chance to be discharged from the hospital with real ECT. Another conclusion is, if compared directly with antipsychotic medications appear to be superior. ECT alone is less effective compared to antipsychotic therapy, which is also in parallel with our own experience. They also do the following. In patients who respond to a low extent to antipsychotic medications, we may do an augmentation with ECT. You may especially speed up the effects of the antipsychotic treatments in the acute phase, and in the poor responders it can be used to augment the effectiveness of the antipsychotic treatment. This is another study in the acute stage. Many studies, including controlled studies, have been included in this meta-analysis. In the acute phase, ECT plus antipsychotic is superior in terms of antipsychotic medications alone. If you look at the results of the study, in the first weeks of the treatment in the combination arm, there is a better response compared to antipsychotics alone. However, in the combination group, this is limited to the first 4 or 5 weeks. This is an important conclusion. So we can speed up the response rate in the acute period. This matches with our clinical experience, especially if you're working in a patient with a high patient for turnover. I think this could be of great benefit to the physicians. In the acute phase, if we wait up, we will get to the same level. However, in order to speed up the response rate, the combination appears to be superior to antipsychotics alone. This acceleration in the acute phase, how does this happen? ECT plus antipsychotic medications look like the effect is expedited. And there is a nice retrospective study, but however, most of the affected patients have been included in the study, with 455 patients with a diagnosis of schizophrenia, schizoaffective disorder, and major depression. And 5,482 treatment sessions have been included in total in the study. ECT monotherapy and ECT plus neuroleptic medications have been compared in terms of global treatment index. And at the end of the day, they find out that there may be some benefits, clinical benefit, from augmenting the neuroleptic treatment with ECT, especially if ECT is added to the atypical antipsychotic agents. Such an effect can be observed. If you look at the chart, the clinical global index, the lower the score is, the better response we observe. And this has been correlated with some EEG parameters, and they found out that the most effective atypical antipsychotic agents in terms of treatment efficacy is post-ictal suppression index. So there is a rapid decline after the ECT session. In summary, the use of ECT in combination with atypical antipsychotic agents, there may be an additive or synergistic effects. What are the atypical antipsychotic agents? There are different hypotheses in this regard. Maybe they may increase the permeability of the blood-brain barrier, thus improve the penetration of those drugs to the brain tissue, or because it may be treating the depressive symptoms, and this is how we can explain those effects, or ECT may be acting on the dopaminergic system, and it may itself exert an antipsychotic effect. Treatment refractory patients, we know 30% of schizophrenic patients do not respond to standard antipsychotic treatments, and in patients who are refractory to antipsychotic medications, clozapine has been shown to be effective. 45 to 70% of those patients don't have a significant improvement with clozapine. This is another comprehensive review. 42 publications, 1,372 patients, and 8 double-blinded controlled studies have been included in this meta-analysis. And the conclusion is, if we look at the open studies without control group, we find out that ECT plus antipsychotic agent combination is both effective as well as very safe in the treatment of refractory schizophrenic patients. But they can't draw a definite conclusion from the double-blind studies. 4 studies appear to have positive results. However, in 4 studies where ECT addition has not shown to benefit, sham ECT could not be used because of ethical concerns. And because one group has responded well to the medications alone, we were not able to find the superiority of the combination of the ECT with the neuroleptic combination. This is another study on the pharmacological response in schizophrenia and the augmentation effect of the ECT. 27 treatment-resistant male schizophrenic patients were included, and they were followed up for 3 years. And ECT was given 2, 3, 8, or to 14 sessions, and then they follow up those patients for 12 months, and they do some clinical assessment. In the 37 patients, the improvement persists for 1 year, and the patients can maintain the condition only using medications. In some 70 of those patients, a new ECT session has to be administered. There is a higher relapse rate among self-harming patients. However, if the ECT is used for maintenance, the self-harming behavior improves. And there are 2 patients who have responded poorly to clozapine, and after ECT, when clozapine is started, remission continues. I think this is the important point. So patients who refuse clozapine or who respond poorly to clozapine after ECT use, with a rapid improvement, the patients may be able to use clozapine again. This again matches with our clinical practice. There may be an additional benefit of ECT in this regard as well. There's another review from 2015, 40 publications, 208 patients, case series, retrospective and open label studies have been evaluated. In clozapine-resistant patients, the role of ECT was studied. In terms of effectiveness, between 37.5 to 100%, there was a short-term improvement. In the follow-up of 3 to 24 months, the improvement has been reported to persist. We have 5 patients who are delirious with tachycardia. In 4 patients, there is extended seizures. This combination is effective and safe and may be used in patients who are resistant to clozapine treatment. But I think this is the most important study. Many of you may be familiar with it. This has been published in 2015. This is the prospective randomized control study on the clozapine, ECT augmentation of clozapine treatment. This is a single-blinded study over 8 weeks. 39 clozapine treatment inpatients are included. They are randomized into 2 groups. One continuous clozapine treatment. In the other group, bilateral ECT in combination with clozapine is administered. In the first 4 weeks, 1, then 3 times a week. In the second 4 weeks, there's twice weekly ECT administration. They use BPRS symptoms, and they set the cutoff value as 40% improvement. Let's take a closer look at the design of the study because it's a bit complex. Initially, you see there's the randomization to the ECT group, and this is the clozapine group. As you can see, in the ECT group we have 50% response rate. However, in the only clozapine group, there is the crossover phase. The patients are crossed over to the ECT treatment. Again, we have a response rate of 47%, and thus we are double checking whether there is a difference in terms of patient characteristics in the clozapine alone period. So this eliminates any doubt that could exist. And in this clozapine group, the mean age looks like it's higher. However, if we give ECT treatment to this group too, we again get a response rate of 47 patients, which is quite high. The conclusion is, in the treatment-resistant severe patient group, there is 50% treatment response. Of course, the cutoff is considered to be 40% of reduction in the symptoms. There is 60% response rate based on conservative measures. And ECT appears to provide the best response rate among all the treatment options. And I would like to touch briefly upon the maintenance ECT. After a successful ECT administration, it may be repeated once a week or once a month in order to prevent relapses. There's a study conducted by Shampatana in pharmaceutical therapy treatment patients who have responded well to ECT, drugs alone, ECT alone, and the combination group were compared with each other, and in the combination group the relapse rate is significantly lower. And this tells us that in the acute period, if there's a good response to the combination therapy, the patients will also benefit from combination in the maintenance phase. This is again from the same study, but here they look at the quality of life as well as social functioning. Initially we had 46 treatment-resistant schizophrenic patients. There are at least 2 antipsychotics that have been tried on these patients, and later on the flupentisol is started in combination with ECT, and what they observed is there's again a similar improvement in DPRS, and if the symptom score is below 20%, and if the patient's condition is stabilized over 3 weeks. However, after 20 ECTs, if the DPRS is still not below 20%, in this case they are considered to be non-responders. 26 patients drop out of the study as non-responders. The second phase is, and these are only patients who have responded in the acute phase. Now these patients are switched to the maintenance treatment. Initially once a week, then twice a week, then 2 to 4 weeks the patients are followed up, and the results show that in this treatment-resistant group, if they respond well to ECT in the acute phase, they continue to respond well in the maintenance period too. So any improvement that we observe occurs in the acute phase. There's only the negative symptoms do not change. However, in the second phase, in the maintenance phase, there's no additional benefit, but the benefit that was obtained in the initial phase can be maintained. There is the social functional scale as well as quality of life scale, and there's improvement in both of the scales too. And this is in line with what other researchers say. So if the ECT has been shown to be effective to be in the acute phase, we should also use it in the maintenance phase. How we should do it, there is no consensus on this out there. This is another study on Shampatana. The ECT needs to be administered very frequently. Considering the side effects and clinical effectiveness, we should customize the treatment based on the patient. And let me briefly touch upon the technical features of ECT. The placement of electrodes, the frequency of the treatment, number of treatments, and the duration of the treatment are important. Unilateral, bilateral, there are no significant differences. However, based on old studies, there is no distinction between acute and chronic, and the sample sizes are heterogeneous. If we could just deduce some conclusions based on the ECT technique, we can say that both bilateral as well as unilateral, but in terms of bilateral ECT, you have a high energy delivery, therefore you have a better response. About the frequency, there's another study of Shampatana, and twice weekly and 3 times weekly have been compared in the resistant schizophrenic patients, and there's a rapid faster response if it's applied more frequently. In terms of the total number of treatments, there is no head-to-head comparison in the studies. especially in acute psychosis. This number of sessions, up to 6, are sufficient in terms of treatment effectiveness. If added to the antipsychotic treatments in numbers between 6 and 12, the clinical remission chances are increased. In patients who are resistant to conventional antipsychotics, we may increase the number of sessions up to 20, and if it's bilateral, there is a better response. About the intensity of the electrical stimulation, there's another study. This is a randomized controlled study. 62 treatment-resistant schizophrenic patients received bilateral ECT. Twice and 4 times of the seizure threshold has been attempted. All those patients are on medications. There's no significant difference in terms of twice and 4 times of the ECT numbers. However, compared to the other group, more ECTs were required. And in order to meet the treatment response parameters, more sessions were required. And I would like to conclude with a final summary of what I've said so far. In patients who are resistant to antipsychotics, after the ECT administrations, you may get a better response to medical treatment. In the acute phase, if ECT is added to the antipsychotic treatment, you get a faster response. In poor responders to antipsychotic medications, ECT may be used for augmentation purposes. If ECT pharmacotherapy is not sufficient to prevent the relapses, and if there's a good response to ECT in acute period, we may consider it in the maintenance too. And we get the best treatment response if ECT is combined with clozapine. And my final 2 slides is about our own experience from our own unit. We've been doing this since 2014, and it's still ongoing. We have 83 patients who have been admitted with a diagnosis of schizophrenia. Male-female ratio is 44 to 39. Average age is 36. So you can see that we use it quite frequently. We did ECT augmentations in around 40%, and almost 60% of the patients did not receive any ECT. And we found out that 50% who receive ECT are on the clozapine. So this, which means the reason that we are using ECT is, apart from speeding up the treatment response, we try to augment the effect of the clozapine. We have exceeded our time frame. In the ECT group, we have more admissions, and it extends the length of stay in the hospital. And this may be due to the fact that we administer ECT twice a week. The PANSS N scores are a bit higher. PANSS P is a bit higher, and the total PANSS is a bit higher too. The mean number of ECT administrations is around 7. This is the score change, PANSS score change. Gray bar are the patients who received ECT, so there is a faster change in the PANSS scores. Thank you very much.